Hysteria never went away. It got rebranded, repackaged. The hysterical woman of the 1800s is now the borderline of today. The symptoms, almost identical. Mood swings, emotional outbursts, self-harm, unstable relationships, sexual acting out. And who gets diagnosed with BPD? Predominantly women, right? And psychiatry may have dropped that unattractive label hysteria. Let's just rebrand it. This has bad branding, bad marketing, right? But the function of the diagnosis is the same, to dismiss and discredit women's suffering instead of addressing the root causes. And the part that really gets me, that I talk about all the time on the podcast, is we're told that we're living into this advanced, progressive society, that psychiatry is more modern now, that we don't believe in wandering wombs and hysteria anymore. But have we really come that far? When a woman is deeply and understandably distressed today, we don't like to look at history. That's why history keeps repeating. And not when you understand that the moment a woman is given that label, her credibility just evaporates into thin air. What shred of credibility we have as just being women, it's completely out the window when that label is being considered. Because if we actually look at a woman's distress seriously, we wouldn't be asking what's wrong with her. We would be asking,
what if everything you've been told about personality disorders is incomplete or maybe even wrong? We're often told that conditions like borderline personality are lifelong, unchangeable diagnoses. But what if these, quote, disorders aren't personality traits at all, but actually adaptations to trauma and nervous system dysregulation? Here's the reality. 75% of individuals diagnosed with BPD report severe childhood trauma, with chronic attachment stress being one of the most consistent predictors. People diagnosed with BPD are 5 times more likely to have experienced childhood neglect or abuse. Today, we are diving into exploring the intersection of complex trauma and personality disorders, specifically borderline. Just a little teaser. You've probably heard us say before, we don't believe in fixed personalities, just frequently occurring reactions. With that in mind, we are going to question in a pretty big way the idea of personality disorders as meaningful diagnostic categories with distinct neurobiological patterns.
This is a big conversation. It's part of a big season where we have been redefining mental health from a neurosomatic perspective, looking at the underpinnings of nervous system health, trauma, and structural forces on many types of quote-unquote diagnoses. So before we dive in, I want to encourage you to listen with an open mind and also to trust yourself. You know what's best for you. Sometimes medical intervention is necessary and helpful. It has its place in the healing journey. Diagnosis has its place in the healing journey, and there's nothing wrong with that. This is an exploratory season, and we're presenting you with a compilation of research showing many different perspectives, interviewing a range of experts on different topics. Nothing is definitive. We want to show you what all is out there and contribute our own understanding of the brain and nervous system, how it impacts each of these topics, and share our experiences along the way. Think of these episodes as audio essays, presenting you with a big picture of things to consider in all of these issues. We're not giving medical advice or saying anyone's perspective is the right way to approach this, but broadening our collective perspective on what mental health really means. Welcome to Trauma Rewired, the podcast that teaches you about your nervous system, how trauma lives in the body, and what you can do to heal. I'm your co-host, Elizabeth Kristoff, founder of BrainBase.com, an online community where we use applied neurology, somatics, and stress processing tools for nervous system health, regulation, and resilience. And I'm also the founder of the Neurosomatic Intelligence Coaching Certification, an ICF accredited course for therapists, coaches, practitioners to bring the nervous system and practical nervous system healing tools into all of the good work you do.
And I'm your co-host, Jennifer Wallace. I'm a neurosomatic psychedelic preparation and integration guide, and I bring your nervous system training and regulation into peak somatic experiences so that you can fully embody and live a life from the messages that you receive and a life that you really desire. I'm also one of the educators at the NSI Coaching Certification, and I am so excited to introduce Mollie Adler, a podcaster, a writer, a creative, an existential thinker, obsessive researcher, and fellow messy human being, trying to find meaning in a society and culture that seemed to be devoid of it. And we couldn't think of anyone better to have this conversation with. She is the host of the podcast Back from the Borderline. And Mollie, welcome to Trauma Rewired. So excited. Would you please share with our listeners some relevant parts of your story that bring us here together today?
Absolutely. I just want to thank both of you, Jen and Elizabeth, for having me. I've obviously been a huge fan of your work for a while, and I love how you both create space for these deep conversations about the brain-body connection and how it intersects with trauma. And obviously, this is a very personal topic for me because, like so many others, I have lived it. And my journey into this work began in around 2021. And like countless people, I found myself at the altar of Google searching for answers about why I felt the way I did. Why did I feel so empty? Why did I feel so broken? And I stumbled across the criteria for borderline personality disorder, or BPD, and had that moment that so many experience. That's so me. This explains everything about me. Tick, 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 every symptom. And like so many others, I felt relief at first. I had finally found a name for my suffering, a sense of direction, and what I felt at that time was an answer. And shortly after that, I started my podcast where I initially focused entirely on BPD recovery. I joined the online BPD community, connected with others who identified with that label, and I myself began to build my identity as a person and a content creator around it. But over time, I started noticing something. The deeper that I got into these spaces, the more I saw people revolving their entire sense of self around this diagnosis. But the thing was, very few of these people seemed to be truly healing. I'm not claiming to be an arbiter of what is healed, but it didn't look like healing to me. It looked like what I describe on my podcast as a circle jerk of sadness, right? I myself was participating in that as well, right? I was just as involved in all of this. But at the same time, I started coming across the work of investigative journalists and other individuals within the critical psychiatry community who were exposing the cracks in psychiatric frameworks. And it made me take a step back and ask some really big questions. Who decided that these labels should exist? What are they actually based on? Are they helping people, or are they keeping them stuck? And for me, these questions were the ones I really wanted answers to, because when I finally found myself sitting across from a psychiatrist for the first time, convinced I had BPD, I was told I was too high functioning for the diagnosis, and was told that he would treat me for bipolar 2 because he told me BPD was considered incurable. And I quote, right? And in retrospect, that moment, which I know we'll dive into more later, that was a huge turning point for me, because looking back on that initial conversation where I put so much trust in that provider, looking for answers about what was wrong with me, made me realize that these categories were far more subjective and arbitrary than we're led to believe. So realizing all of this, I took a risk. It was really scary, but it was the only thing that at that time felt aligned with my integrity and the direction that my healing was taking. I shifted my podcast completely away from focusing on BPD and instead started exploring the broader picture: depth psychology, trauma, the nervous system, generational patterns, and even spirituality, and how all of those things intersect. And that's where I found real healing. And when I say real healing for me, I felt change and transformation and integration, not in a diagnostic label, but in zooming out and understanding my experience beyond a disorder. And that's why I'm here today, and why I do the work I do on my podcast, because I believe we need to rethink the way that we frame mental health. And it sounds like that's what you're doing with this series, not as a set of fixed disorders, but as a survival adaptation, as messages from our nervous system, and as invitations to a deeper self-understanding rather than an incurable life sentence. And I know this is a huge conversation, And I'm really excited to be here and discuss this sensitively as I can. I'm inherently pretty firm with this because I've seen too much and I've read too much, and you'll hear about that. But I'm really stoked to be talking about this with both of you and have the immense honor to share what I've learned along the way with your listeners.
Thank you so much for sharing all of that. And I relate so much to many parts of your story. I'm someone I was diagnosed with many things as an adolescent, including borderline personality disorder, including bipolar 2, including lots of anxiety disorders. And I've talked about this on the podcast before, but as an adolescent and through my early 20s, I was living my life flailing around, just seeking relief. Like that might come through self-harm or substance abuse or compulsive exercise, eating disorder. I was just in so much pain and reaching for everything. And through that whole time was being constantly connected to this identity of diagnosis, and a very deep belief formed that I am broken, I'm crazy, and that I ruin everything, that I'm a ruiner. Like it was just, and being so entrenched in all of these diagnoses really solidified those beliefs for me. And there was so much shame, and all of that got turned inward. And it was really as I began to learn about the nervous system and to learn about trauma and to start to connect some dots to see these are not abnormal reactions given the experiences that my little body and developing brain and nervous system went through. There's nothing disordered about the way that I'm acting. It is a result of the experiences. And so as we've, continued this work, Jen and I on the podcast, more and more, we really challenge this idea that anything is fixed, right? We're neuroplastic beings. We're constantly adapting. And all of our behaviors are outputs of our nervous system doing the best that it can to keep us safe. And so I'm really excited to dive into this topic. I do want to, just for people who are listening and not familiar with what personality disorders are, its traditional definition is that it's an enduring pattern of an inner experience and behavior that deviates, have issues with the whole definition here, that deviates significantly from cultural expectations, right? Like whose expectations are these? And are pervasive, inflexible, like we know we're not inflexible, we're dynamic beings, beginning in adolescence or early adulthood. I believe it goes far back to ancestral, generational experiences, are stable over time and cause distress and impairment. So we're really looking at this concept of frequently occurring reactions driven by dysregulated nervous system, chronic stress over time, and developmental trauma. So Mollie, would you want to share a little bit more deeply into that story of your bipolar 2 diagnosis and being classified as too high functioning and how that led you down this path?
Absolutely. I already shared a little bit about that initial experience with psychiatrists, but what really made me start questioning the entire diagnostic framework was just how subjective and honestly inconsistent it all was. The first psychiatrist I ever saw met me for maybe 15 minutes. And anyone who's seen a psychiatrist, those appointments are not long. They're quick, it's in and out. And I'm not speaking for all, by the way, the majority of people I hear from. And I am not just speaking from my own experience. I get hundreds of emails about this all the time. And so I know for a fact, because I've spoken to a few amazing psychiatrists. I had Judy Safrir on my podcast a while back, who is a psychiatrist who works with medications, but she's also critical of her profession and informs herself about the mind-body-brain connection. And so I want to start all of this off by saying not all mental health professionals, not all psychiatrists. So I'm critiquing systems. That's what I do. But I went into this psychiatrist's office fully convinced I had BPD. And for your listeners that are listening on audio, it's big air quotes. You can definitely hear my air quotes on the audio when I say these things. But I had researched exhaustively every symptom, checked every box, and I was sure that was the answer. But he dismissed me almost immediately. And he said, trust me, you don't want BPD. It's incurable. And besides, you're too high functioning. And instead, he said he'd treat me for traits. I never even really got a formal diagnosis of anything. He said he wanted to treat me for traits of bipolar 2 because, according to him, that was more manageable with medication. And at the time, I trusted him completely. I hadn't gone down any of these rabbit holes. This was Mollie before the podcast. I'm just like, please, oh, amazing psychiatrist, tell me what's wrong with me. Give me the answers. I went in willingly, which I think is interesting, Elizabeth, like different to your story, like someone who is being put in against their will into a psychiatric hold. I went in wanting answers with my little homework sheet saying, here's what I've got, doctor, just tell me. And I walked out of that office with a prescription for Lamictal, which for listeners who aren't aware is a mood stabilizer, and Xanax, thinking I had some kind of chemical imbalance that could be fixed with the right prescription. And most importantly, I felt relieved because I had been told that I didn't have BPD, which in my mind now meant that I was broken beyond repair. But something didn't sit right with me. I had resonated with every single symptom of BPD. So why was I being told that I didn't have it just because I presented as high functioning? Is it because I had my makeup done? Is it because I was articulate? I was deeply suicidal at the time. I barely left my bed. I had a jar of almond butter next to my bed that I was eating because I didn't want to leave my room. So what exactly was high functioning supposed to mean? And then it happened again. I saw 2 more psychiatrists after that, and they all had different opinions on what was wrong with me. But the one thing that they'd agreed on was that they told me in no uncertain terms to stop pushing for this BPD diagnosis. And at one point, I actually confronted one of the doctors or psychiatrists rather and said, like, I don't get it, right? I meet all of the diagnostic criteria. So why won't you just give me the diagnosis? And I think a lot of people feel this way, right? It's like, give me the diagnosis. It's almost like when you get your blood work done, it's not that you want something to be wrong, but you feel like crap. And so you're like, there's got to be something wrong. And they say, no, your blood work is fine. And you're going, but there has to be something. You want the doctor to give you the diagnosis as if it would actually fix it. And I spoke to his receptionist afterward to book my next appointment, and she said, Mollie, in confidence, he is doing you a favor. If you get this diagnosis of BPD, it's going to follow you. It could impact your ability to get life insurance. It could affect your chances in a custody battle of a future child or children one day. Just let it go. And that was a huge wake-up call for me, because if I was being warned away from this label, then who exactly does deserve to carry this label? Who gets slapped with a diagnosis that could literally affect their legal rights? It made me realize that psychiatric labels don't just describe symptoms, they are categorizing people in ways that have real-world consequences. And we see this play out all the time. Think about the way personality disorder diagnoses, especially BPD, are weaponized, especially against women. A really public example of this happened during the Depp versus Heard trial. A psychiatrist that was hired by Johnny Depp's legal team literally armchair diagnosed Amber Heard with BPD and histrionic personality disorder. And overnight, that became the entire narrative around this person. Now, regardless of what anyone thinks about Amber Heard or that trial, I'm not even going there because I'm not even deeply informed about that. But the way that the label was used in that trial is undeniable. It wasn't a neutral thing. It was meant to discredit her, to make her seem manipulative, unstable, and fundamentally untrustworthy. Whether her actual actions prove that out are neither here nor there, but the label was used in that way. And that's exactly what happens to everyday people who get these labels too. And it goes beyond public perception, because when I first started digging into this, I came across something that completely floored me. There was a time when, in California, people in prison could apply to have their sentences commuted. But if you had a diagnosis of BPD, you weren't eligible. And the same went for narcissistic personality disorder. And get this, for convicted sex offenders. So think about what that says. It means that legally speaking, people with a personality disorder diagnosis were placed in the same category as convicted pedophiles. Let that sink in for a second. What does that tell us about the stigma attached to these labels, about how society views people with these diagnoses? And that's when I realized I wasn't just questioning this diagnosis anymore. I was questioning the entire framework that creates and enforces these labels. Because if a psychiatrist tells me, no, you don't want this label, it's going to ruin your life, then maybe the real question is, should anyone have this label? Should we really be labeling people in ways that can be used against them in a courtroom? Should we be diagnosing people with something that could impact their ability to get housing? Should we be diagnosing people with something that could impact their ability to get insurance, life insurance, legal protections? That's when I knew I had to start questioning not just my own diagnosis or lack thereof, according to these psychiatrists, but the entire framework that created these labels in the first place.
Thank you so much, Mollie. Thank you to both of you just for your willingness to be so open and share your experience with this diagnosis and what you have been through. I think it's really beautiful to, hear. And I found my body responding so much to the things that you were saying, Mollie, just around, there's just so much about this conversation that when I think about like the gaslighting of women and, just there's going to be a lot to explore here in this conversation. And, many of what we call personality disorders, they share a set of core characteristics that contribute to long-term emotional and relational instability. And so while personality disorders present with unique features, many traditionally exhibit intense emotional reactivity, fear of abandonment, and relational volatility, and then, of course, chronic dysregulation. And so with like intense emotional reactivity, we talk about it a lot here on the podcast, but many individuals with a personality disorder experience emotions that are quick to escalate and often very difficult to regulate. Emotional responses are often disproportionate to the triggering event, making it challenging to maintain stability in relationships and in daily life. The fear of abandonment is often very deep rooted. That fear of being rejected is a hallmark of many personality disorders, especially those with attachment-based difficulties. And this fear, this could look like behaviors like around clinginess, efforts to maintain relationships, or like a more of a frantic efforts to maintain relationships, preemptive distancing to avoid perceived rejection. And, individuals with BPD may go to really extreme lengths to prevent abandonment, even if that abandonment is imagined. And in dependent personality disorders, another one, there may be a persistent need for reassurance and difficulty making decisions independently to avoid potential rejection. And then we have relational volatility. And we spent a whole season on Trauma Rewired, right? Talking about relationships, or a complex trauma is an attachment wound, because emotions and fears are so intense. Relationships tend to be unstable and marked by cycles of maybe idealization and devaluation. Someone with BPD may alternate between idealizing a partner, like seeing them as perfect, and devaluing them and viewing them and maybe as entirely bad. And it's based on minor perceived shifts. And so while personality disorders are diverse, these traditional characteristics often overlap, and they lead to patterns of emotional instability. They're going to lead to interpersonal struggles and difficulties in self-regulation. And, like I said, we spent a whole season talking about complex trauma and attachment, and we know that early attachment experiences play a critical role in shaping the brain's threat response system. When caregiving is inconsistent, neglectful, or traumatic, the developing brain adapts by becoming hyper-attuned to threat, often at the expense of emotional regulation and relational security. And these adaptations involve the limbic system, the ANS, the autonomic nervous system, and stress-related neurotransmitters. This leads to long-term patterns of hypervigilance, emotional instability, and maladaptive survival responses like chronic fight, flight, freeze patterns. And so this could look like limbic system overreactivity, that hypervigilance and emotional reactivity. The dysregulated ANS is going to be looking like chronic attachment stress sensitizes the ANS, right? Leading to that chronic fight, flight, freeze states. The sympathetic nervous system responsible for fight or flight may be overreactive, resulting in chronic anxiety, agitation, and impulsivity. Conversely, the parasympathetic nervous system could be in a more dorsal vagal response, right? That freeze, that flop, leading to responses that are led by dissociation, by shutdown, and that emotional numbness. So over time, all of this dysregulation, it contributes to chronic emotional instability, once again, and difficulty for calming down after experiencing distressing situations. And so we know that early attachment trauma fundamentally alters brain architecture and nervous system functioning. And many individuals, and I think as y'all are describing, disorders live in a constant state of nervous system dysregulation, cycling between hyperarousal and hypoarousal. It's a lot to carry. It's even a lot to hear, maybe, for your nervous systems and for the nervous systems that are listening to this.
Yeah. Emotional reactivity, the fear of abandonment, the relational struggles, the difficulty regulating emotions, this is the lived experience of so many people who end up receiving these personality disorder diagnoses. And the way traditional psychiatry frames it, these are signs of something being wrong with you, that you're somehow wired incorrectly, or worse, that your personality itself is fundamentally disordered. But if we step back for a second, what if these aren't signs of pathology at all? What if they are signs of, as you described, there are signs of adaptation? And that's what I talk a lot about on my podcast. These behaviors and emotional responses aren't random. They are hardwired into us through experience. When we're children, our nervous system is constantly taking in information, adapting to our environment, and teaching us how to survive that particular environment with our particular nervous system. You both talk beautifully about this all the time. I was a listener and fan of your podcast before I became, friends of both of you. And if we grow up in instability, if our caregivers are inconsistent, neglectful, or even outright abusive, our system learns to expect that love is unpredictable, that connection can be dangerous, that emotions get you punished or abandoned, and so we adapt. And a child who grows up in emotional chaos learns to become hypervigilant because predicting danger means you are safe. And a child who experiences chronic invalidation learns to suppress their emotions because expressing them leads to rejection or worse. And a child who grows up with instability is likely going to cling to relationships in adulthood, fearing abandonment at all cost, because losing connection once when they were little meant losing everything. And these are not disordered reactions. These are perfectly logical survival responses. And the problem isn't just that psychiatry fails to recognize this, it's that psychiatry actively reinforces the idea that these patterns are who you are, that you were somehow born like this. But we now know, thanks to research in neuroplasticity, trauma, nervous system healing, that nothing about us is fixed. As you've already said here, Elizabeth brought that up as well. People heal, brains rewire, trauma can be processed. The idea that a personality could be incurably disordered is actually laughable now that we know that people recover from catastrophic brain injuries, for God's sake, that people survive profound trauma and come out on the other side completely transformed, that we change through insight, relationships, and experience. For example, if Elizabeth presented in front of a psychiatrist and told them today that she had BPD, the incurable personality disorder, no one would believe her, right? So she'd be gaslit again. So given everything that we now understand about the brain's ability to heal and rewire, I have to ask, right, how archaic is it to suggest that a person's entire identity can be permanently disordered. And then that leads us to the bigger question. Who decided that these disorders exist in the first place? Right? That's the real question that we're here to talk about. And this is where we start getting into the real cracks in the system and where I do a lot of my research on my work, because these diagnoses weren't discovered, right? They were created. And that's an important distinction, right? For example, cancer was discovered. We discover these illnesses that can be treated and hopefully eradicated, sometimes not. But these diagnoses are not scientific. They were created. The DSM, which is the Bible of Psychiatry, it wasn't written by some team of brilliant neuroscientists uncovering biological truths about the human brain. It was put together by committees of psychiatrists, primarily men, who literally voted on what should be considered a disorder. They didn't run brain scans. They didn't do genetic testing. They didn't uncover biomarkers in the blood. They sat in a room and debated it. That's how psychiatric disorders came to exist. Something we don't spend nearly enough time talking about is that every time a new edition of the DSM comes out, new disorders magically appear. The reason for that is because the more disorders there are, the more treatments can be prescribed, the more insurance companies can bill, and the more pharmaceutical companies can push for new medications. And this is where we need to think very critically. You know what they say, follow the money. So what happens when we follow the money? Do you know how much money the American Psychiatric Association makes every time they release a new DSM? Millions. Psychiatrists and institutions have to buy new copies, insurance companies adjust their billing codes, drug companies develop new marketing campaigns around the disorders, air quotes, in this new edition. This is not mental health care. It's an industry. And industries aren't designed to heal you. They're designed to keep you in the system. There's a saying that rings very true here. A patient cured is a customer lost. And so this is where I had my final aha moment. You need a diagnosis to get mental health treatment. And if you want insurance to cover your therapy, you have to be labeled with something. Therapists out there listening will know this. I speak to them all the time. I get emails from them. Therapists who reject this framework, and there are many of them out there who in their minds reject it and wish they don't, or they actively do. They don't want to slap labels on people or participate in the system. They're often forced to work outside the insurance systems entirely. That's why you find therapists who say, I don't take insurance. And I was one of those people saying, oh, greedy therapists. You know, when I was looking, how could they not? Now I understand why, right? They're doing this because of usually for their own integrity or their type of treatment modality that they offer. Maybe the kind of treatment Jennifer offers, even a Jungian depth psychologist. They're not covered by insurance because their things can't be measured in these tight little packages that insurance companies want. So the very structure of mental health care is designed to keep you in the diagnostic system. You must be disordered to receive care. And if you really think about it, it's pretty twisted. And the next logical conclusion is if these diagnoses aren't real diseases, if they are just labels created by committees, then why are we being taught to believe that the problem exists inside of us? Why are we being told that we have disordered personalities, broken brain chemistry, instead of looking at the environments, the systems, and the power structures that benefit from us believing all of this?
Yeah, I think what you were mentioning a second ago about the subjectivity of these diagnoses was from the definition that it is an experience or behavior that deviates significantly from cultural expectations. And what are those cultural expectations? And as Jennifer was listing out kind of the traditional characteristics, again, air quotes, traditional characteristics of these personality disorders, I just have to think of that they don't just reflect the outputs that we see with CPTS, they are the same, right? When we talk about all of season 3 as complex trauma being a relational wound and the relational volatility, the maybe feeling like you have to be very attached to someone and at the same time pushing them away or being critical. Of course, that is an outcome if relationships are inherently threatening, right? If you both need attachment for your survival And there's a huge stress load that comes with that attachment. And then you have those competing needs of I need the attachment for my safety and survival that was imprinted very early on. And there's an extreme load of stress and dysregulation that comes with trying to maintain that attachment. So, of course, you would be hypervigilant, hypersensitized to maintaining the attachment in adulthood, right? These patterns persist. And at the same time, as a defensive mechanism from all of that stress, there's a part of you that is protecting you from that connection by also looking at how you're going to be hurt by this person, being critical of them, pushing them away, keeping a wall up. And those things are competing all of the time. And it comes from the relational patterning of our past experiences, not because there's something that was inherently wrong with our brain. It is the adaptation that you spoke to, Mollie. It's how we are as human beings, little developing brains and nervous systems, constantly looking for what behavior can I produce, what physiological response can I produce inside to keep me alive in the world, socially, emotionally, and physically safe, right? And those responses become our neural patterning, and they persist, but we're always continuing to adapt. And so as you were also saying, Mollie, like if I presented myself to someone today, this is not an incurable condition. It's a well-worn response, right? It's a well-myelinated path. But as I move through my life and I cultivate new relationships and I create regulation and safety inside of my nervous system, I remobilize my diaphragm and my vocals and work with my body to be able to express and emote and regulate around that, the patterns change. And then I change, right? I would no longer meet that diagnostic criteria because the same responses aren't occurring because I've adapted differently, because I understood how my nervous system works and I understood the trauma patterns. And so that gave me some agency to work with it, but it's nothing that's fixed. And so these are all outputs, like we talk about here all of the time. The emotional volatility, the emotional reactivity, the relational volatility, the fear of abandonment, the chronic dysregulation. These are the outputs. What are the inputs that have come in to create those outputs? What are the inputs? How does my brain interpret those inputs? And then what output does that create? And when I understand that input, interpretation, output, I can begin to work with my system to start to create some change. And that gives me a lot of agency in my life rather than having to stay in the paradigm of a system that I don't believe in.
Yeah, I've joked on this podcast a couple of times that, I mean, I have not ever been officially diagnosed with a personality disorder, BPD or borderline. And it's only, I think, really because of the misattunement. Had my primaries been more attuned, I think they would have seen that. I mean, there's just no way my pendulum was swinging so hard all the time. And when I think about my like 18 to 25, maybe even 30. I mean, these were just wild, reckless times on top of all this, the lack of safety I was feeling in the world. I have an ACE score of 4. I was self-medicating in several different ways. I was sexually fawning. I mean, the emotional neglect that I had experienced. I mean, I relate so much when I was doing the research. It was like, yes, it's always been a yes for me in my body that I do have, or did at one time have, what would have been diagnosed as BPD, 100%. And I wonder how many other women out there listening to this conversation with an average to high ACE score have not had all of these same experiences in their lives at one time or another. And I was really trying to reflect on, how did this maybe naturally start to taper off, right? Because I think when, after my 30s, then there was like, I was kidnapped for sex trafficking. That obviously, contributed to its own level of stress, and then breast cancer. And it must have been breast cancer that really started to help taper some things out for me, where I was really starting to just maybe even seek more balance and holistic health in my life, quit the alcohol, and really stop adding any of those like additional substances. I cleared out a lot of toxic products in general, not just drugs and alcohol, like toxic products throughout my life. And I think that really played a big deal in helping to sort of settle things down for me. And then, of course, I've experienced a huge shift since I came into NSI. And now I really do have tools to regulate and just work in my brain and body. But I hope to hear from some of our listeners today through this conversation about how relatable this is for people.
The way that you're both describing this, I agree. What woman out there that's listening that is definitely tuned into this podcast and mine hasn't felt this way, hasn't felt like they are screaming out for recognition and they don't know how. I felt like that was the description of my childhood upbringing, because I didn't experience outright abuse, but it was this chronic drip feed of childhood emotional neglect where I felt like I wasn't seen. I called myself like an emotional feral child, where I felt like I had to raise myself. No one told me about morals or what I should do. I also felt like I was just always wanting the attention of my parents in some way. And that translated, and my adolescence converged perfectly with the advent of social media and MySpace, which was a hotbed of men that were predators preying on girls just like me, wanting to abuse and groom me, which that's what happened. And that's how it led to my experience of sexual assault that I felt like I was participating in. Total gaslighting, and I could only unpack it years and years later. But just like Jennifer described, total sexual fawning, totally wrapping myself up in what I called the hot girl box on the podcast. I was presenting myself in any way to get validation and love, and it just did not and obviously I was inadvertently attracting like moths to a flame the worst possible men because of this. And so then it further reiterated into my brain that men bad, men scary, men abusive, you bad, something's wrong. Why are all these people around me finding these healthy relationships and yet. And so, and I also, to your point, I won't go further down that rabbit hole. Same thing with you, Jen. I started getting rid of some of these toxic products. I found out that birth control really did not agree with me. Again, might be different for people. I tried every kind, and it did horrible things to my ability to find any kind of psychological grounding and centered place. And so, but all of these things, and then just never mind the environment we all grew up in. Look at how the media spoke about women. We often find ourselves blaming parents. It's not just parents. It goes so far. I talk about zooming out on the podcast. So given all of these things, of course we felt the way that we did. And now that we remove ourselves, if we're lucky enough to do that, find ourselves listening to content like this, you start to go, it makes perfect sense. Of course you're not disordered. It was a perfectly understandable reaction to the system, society, and it's all designed to make you feel like something's wrong with you.
I think it's so important to look at this at that individual level and the structural level, like you were talking about, Mollie. I think it's really important here today for this conversation that we really talk about these big forces. And one, definitely we're looking at the trauma underpinnings of this, that there is a huge link between the way that our behavior and our personalities adapt given our life experiences. You've heard us say on here many times, we take the D off of CPTSD because there's really nothing disordered about that. 81% of participants in a study on the American Journal of Psychiatry found that 81% of participants diagnosed with BPD had significant childhood trauma, including physical abuse, including sexual abuse, including witnessing serious domestic violence. These things are the waters that we're swimming in, the way that we're developing, and that is real in there. But there's also this component of systemic trauma that you're talking about, Molly. It's not just our personal trauma, right? When our society is structured in a way that denies people safety, belonging, social support, our nervous systems start to reflect that when these harms are put onto our body, onto our nervous system by the way people talk about women or the way people talk about other marginalized identities, right? That impacts our nervous system and the way that we adapt. And our nervous systems are always reflecting these structural forces as well. And that's why we see these same patterns of dysregulation coming from a systemic and structural level too, right? In communities with generational trauma, with people who have lived under systemic oppression. And so I want to keep broadening it out in that way too, because I think we have to look at all the different forces that are contributing to these diagnoses.
100%. I mean, our society has been so damaging to women and really bodies. Just the idea of the ownership over other people's bodies, the rape culture that we particularly we grew up in. And rape culture is a societal environment that normalizes or minimizes sexual violence. And it's contributed, our rape culture is contributed to high rates of BPD, particularly diagnoses in women. And research strongly suggests that sexual trauma, chronic invalidation, and systemic misogyny play a significant role in the development of a BPD disorder. And I think sexual violence in general is something that we have to bring into this conversation around BPD and these diagnoses. I mean, when I think about my own life and reflection, you know, a big piece of my dysregulation is sexual in nature.
I couldn't agree more. I think that, and I will speak a bit to that, and I don't want to get ahead of both of you, but it's so hard to talk about something like BPD and not talk about sexual violence, because a lot of people that find themselves slapped with these types of diagnoses are people who make accusations and then are gaslit or are told that they're imagining things, or that what were you wearing? Were you the manic pixie dream girl, right? We could talk all about these things. And it is an absolute gaslighting of the reality of sexual violence. And so it's almost impossible to discuss something like BPD, histrionic personality disorder, any of these ones that are weaponized against women, without talking about sexuality. Because many times, I don't know if it's in the actual criteria, so someone can absolutely fact check me on that, but I do know that what is it? Sexual, like promiscuity, or the phrase I hate more than anything, sexual acting out, is another thing that's often associated with something like BPD. And doesn't that sound like an old Victorian school marm? Like you're acting out sexually. Why?
What most healing and personal development programs don't tell you is that your patterns, your behaviors, your emotional responses are outputs of your nervous system trying to keep you safe. And changing your thoughts won't change those deep-rooted patterns. You have to go deeper. Inside rewiretrial.com, you'll learn how to train your nervous system for greater capacity so that you can navigate life with more ease, more presence, more connection. We have 5 live classes a week with expert instructors. We have an on-demand library with thousands of recorded neurosomatic training sessions. And we have an incredible, supportive, inclusive community of people just like you doing this deep work together. You don't have to keep fighting against your own nervous system. You can repattern it. Start your 2 free week trial now at rewiretrial.com.
Why? I love the phrase you used, Jennifer, sexual fawning. Why is that happening, right? These things don't happen in a vacuum.
I do want to dive into the history of hysteria and all of that as well, but I just want to chime in a little bit on some of this with the history of sexual abuse and sexual assault and all the experiences that we have, not just in our early childhood development, but later through life, right? And in our 20s and our 30s and whenever. Because one, many women diagnosed with BPD have histories of body boundary violations, right? That could be sexual abuse, could even be like medical gaslighting, forced compliance, relational control. But big picture, all of this at a deep level, our body is, especially if this happens in early childhood, we're learning that it's not safe to set boundaries, to stay in our own body. Dissociation becomes a well-worn pathway. And that leads to really complicated relational patterns where it is life-threatening inside that physiological response whenever I try to set a boundary, whether that's, you know, in a work relationship, or in a sexual fawning situation, right? I find myself in these situations. I do not have the skills setting a boundary, using my voice, staying present in my body, knowing what I really want. These are not skills that my nervous system has developed. And what has been patterned over time is repression of my emotions and my needs, dissociation and abandonment of self, placating the predator for my survival. And this is the way that I move through the world. And then that trauma compounds. And we also learn to suppress a lot of our emotions, suppress or repress at a really reflexive level. And so when you get to that emotional reactivity, there's going to be rage and anger from these body boundary violations. But also, I have been trained, conditioned, learned, developed, adapted, where expression of my anger is not safe. So I have all of this rage, I have all of this anger, and I'm holding it all inside. And it's going to erupt at times. It's going to come out in my relationships in ways that I don't want it to. It's going to come out on myself in self-harm. It's going to come out and manifest as autoimmune and inflammation and disease in my body. And so this history of sexual abuse definitely plays into the way that these behaviors that are diagnosed are formed.
And the repression of sexual abuse, we don't talk about it. We have learned generationally through our ancestors that we don't go to talk to the authorities about the sexual violence that we encounter. It's just easier somehow that we're just supposed to metabolize the body boundary violation, the rage, the anger. I mean, there's so much resentment, I think, of women to the system. Like, there's so much violation that comes through the system. And just, I think here in Texas, women were still paying for their rape kits up until almost the 1970s. What are we talking about? Like, we have never been, none of us have been raised in a system that protects us. And throughout history, women who have exhibited any emotional distress due to trauma were frequently labeled as hysterical, unstable, overly emotional. It's led to forced institutionalizations, forced treatments, medical gaslighting, which we've talked about so much today already. And it's versus real, genuine support. Even just an ear of understanding is so powerful. But societal structures that have normalized gender-based violence, silent survivors, and limited female autonomy further compound psychological harm, and it makes healing really difficult. And the legacy of historical mistreatment persists today, as women with complex trauma are still more likely to be misdiagnosed, over-medicated, or blamed for their symptoms rather than offered real trauma-informed care. And there are really deep-rooted connections between being a woman, trauma, and mental health stigma. And it's crucial for us in this conversation to help shift this toward more compassionate, evidence-based approaches that validate and empower women and survivors of the system.
If you're comfortable going in the hysteria direction, are you both comfortable going there? Because it's the perfect segue, really, because to Jen's point, for centuries, instead of asking what happened to her, the system responded by saying what's wrong with her. And that's, I think, part of the reason why so many of us and our four sisters have decided to say, screw it, I'm not gonna even go forward because I see what happened to her and I don't want that happening to me. This is enough to deal with as it is without being told I'm attention seeking, that I am the crazy one. What were you wearing? Were you asking for it? Were you hypersexual? All of these horrible things. I mean, just look at how people like Britney Spears were treated in the media. These, it's really wild. But this isn't new. And this is where I did a lot of my research to make sure I could bring some really interesting stuff for your listeners, because it's an open secret, really, that psychiatry has always had a problem with women's emotions. And if we want to understand how we got here, having this discussion, how BPD became one of the most weaponized diagnoses for women, we have to look at where it all began. And that was with something called hysteria. And the history of hysteria is absolutely insane when you really look at it. The ancient Greeks believed, actually, that if a woman was acting out, there's that word again, moody, emotional, unpredictable, what have you, it was because her womb was literally wandering around her body, causing mental instability. That was the science of the time. They called it hysteria, and the treatments were just as crazy. Some doctors thought sex would cure it. Others used bloodletting. And if your listeners don't know what that is, right, it's like you imagine the leeches or cutting and like letting out extra blood, or even surgery. And I found out that this is actually where hysterectomy actually gets its name. Women were literally having their uteruses removed as a treatment for manifestations of this psychological suffering. For listeners on audio, Jen is just shaking her head. We are all doing it because this was actually happening. So fast forward to the 1800s and early psychiatry, right? Nothing changed, except now, instead of saying your womb was wandering, they said that you were hysterical. And if you were too sad, too anxious, too angry, or God forbid, accusing a powerful man of sexual assault, you were locked away in an asylum, drugged, subjected to treatments, air quotes, like forced sedation, lobotomy, hydrotherapy, electroshock therapy. Women weren't being helped, they were being silenced, and they're still being silenced today. If you're too emotional, too intense, too much, you get sedated, institutionalized, or diagnosed with something that invalidates your very real and understandable suffering. And this brings us to one of my favorite topics, which is Freud, the daddy of psychiatry, because he had a moment where he almost told the truth. He started noticing a pattern. So many of his female patients were describing eerily similar experiences of sexual abuse at the hands of men in power, some of them being in their own family. And he was this close to saying, wait a minute, I think I found the real issue. But instead of standing up and saying women are being sexually abused, he folded, he chickened out, and he created theories like the Electra complex, saying women aren't actually traumatized. They're just acting out, there it is again, unresolved subconscious sexual material or fantasies. He turned their trauma back around onto them into a psychological flaw. And that moment, that cowardice, that decision to protect the system instead of the women suffering underneath it, shaped psychiatry as we know it today. Hysteria never went away. It got rebranded, repackaged. The hysterical woman of the 1800s is now the borderline of today. The symptoms, almost identical. Mood swings, emotional outbursts, self-harm, unstable relationships, sexual acting out. And who gets diagnosed with BPD? Predominantly women, right? And psychiatry may have dropped that unattractive label hysteria. Let's just rebrand it. This has bad branding, bad marketing, right? But the function of the diagnosis is the same, to dismiss and discredit women's suffering instead of addressing the root causes. And the part that really gets me, that I talk about all the time on the podcast, is we're told that we're living into this advanced, progressive society, that psychiatry is more modern now, that we don't believe in wandering wombs and hysteria anymore. But have we really come that far when a woman is deeply and understandably distressed today? We don't like to look at history. That's why history keeps repeating. And not when you understand that the moment a woman is given that label, her credibility just evaporates into thin air. What shred of credibility we have as just being women, it's completely out the window when that label is being considered. Because if we actually look at a woman's distress seriously, we wouldn't be asking what's wrong with her. We would be asking, what has she had to survive to get to this point?
As I'm listening to you, Mollie, talk about the diagnosis and the stigma that comes with these disorders and the natural expression of what our body and our nervous system need to be able to process the traumatic experiences that have happened to us, right? Like, in order to, I don't even want to say heal, but in order to maintain our health and to create regulation, we have to be able to mobilize those emotions. And with these big experiences, there's a big emotional charge, and we're not able to because of the now I'm going to be labeled this way. I'm going to be shut down. I'm going to be labeled as crazy. That label will become internalized. It will affect my relationships, my job opportunities, my legal rights, all the things that we talked about in the beginning of the episode. And it becomes coupled with so much shame, which is an immobilizing emotion that keeps us from being able to process and move beyond these experiences. And so that all of that emotional energy stays in our body. It creates pain, it creates illness, it creates constant states of dysregulation. And shame is, we've talked about it here many times, it's ultimately a protective emotion, right? It's protecting us from severing attachment, and that includes attachment to society at large. And so if we have these structures that are going to punish us for the expression of our emotions and for speaking the truth about our experiences and acknowledging the what happened underneath the behavior, shame becomes this natural emotional response to keep us socially safe, to keep us connected, attached to one another, and safe in our society. Like, I'm staying within the social norms by continuing to repress this. And so we have this now shame response that becomes very, very hardwired and very reactive. And we have to remember too that not only is it a protective emotion, but it is a neurophysiological response in our body that is immobilizing us, that's moving us into a freeze state, that is creating inflammation in our body, that has all of these physical consequences on our health as well as on our behavior. And so now we begin to lose skills of emotional processing. We get sick, and that shame keeps spiraling on itself, right? Then we have the sickness, we have more dysregulation, and then there's more shame about that.
Yeah, shame is so layered. I mean, it comes into the experience so layered too. Like, we've talked a little bit about sexual fawn, but shame was really coupled for me in my identity through pleasure, through like the confusion of pleasure and shame, because I'd had so many different body boundary violations really throughout the course of my life, really up until, I guess, probably like, I mean, it's crazy, right? I don't even know, probably up until like yesterday, right? When hasn't someone crossed the boundary, And when I think about like shame and pleasure and that overcoupling and body boundary violations and like how I acted out sexually, right? Air quotes, acted out. I was objectifying myself. I was so confused. The emotional neglect was so harmful and really overbearing that I think really drove an emotional experience into sexual pleasure. but often always just like harming myself and living in so many cycles of shame. And, you know, that shame response, it's cognitive, it's a full physiological response in the body. And I didn't understand emotional processing. I mean, had any of us understood emotional processing, would there be a bipolar disorder, right? I mean, would that even exist if we understood emotions as a society and as women? Like it, for me, so much of this comes down to emotions and like acceptance, societal acceptance. And like Molly, you said something earlier about like, what were you wearing? Did you deserve it? And like the hypersexuality. And it's so confusing to be a female in this world when you're supposed to be all of these things over here, but not be any of these things over here. And all of these things are like interwoven together. And then it, once again, more shame. Shame for the things I am, shame for the things that I'm not. And this, it really shuts down shame. It really shuts down connection. It suppresses our voices, our authentic full self-expressions, our power. And it protects, as a protective response, it's protecting all of the other emotions. So we're not experiencing our joy, our rage, which is so valid, right? The grief and the fear and everything that it's okay to experience as a woman in the society that we are moving through today.
If people could hear just what you shared, imagine if a young girl who was on the brink of getting a diagnosis found herself instead in front of Jen and heard what she just heard. Just the very act of hearing that, it's okay. It makes sense why you're feeling this way. Yes, let out your rage, feel your feelings. It's not okay that you've been violated. There's nothing wrong with you. It's society, and it's not going to go away. It's not going to be fixed. There's no pre-trauma purity that you're going to go back to. I talk about this on my podcast all the time. There's no version of yourself that you're going to get back to. That's a myth. But we're being sold everything. But all people need to hear, all young girls, we're talking about them now, need to hear is what Jen just said. And it's not that that fixes you or cures you, but that's the medicine. That's the medicine we need to hear. And it's so good that we're talking about shame, but I want to even take it a step further because I don't think it's just shame. It's toxic shame, because I think there's a big difference between healthy shame and toxic shame. I don't think I know. And healthy shame, right, is what keeps us in check. It makes us reflect when we've maybe hurt someone, which we do all the time. We do these mini ruptures in our life, rupture, repair, rupture, repair. The reason why a lot of us end up with disordered patterns of behavior is there's rupture, 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 rupture without any meaningful repair in our relationship. But that healthy shame is what you feel when there are those little ruptures in relationship. It's what helps us align with our values, right? It's a good thing. But toxic shame is that voice that tells us, I am bad. I am inherently broken. I will never change. And if we're talking about shame, that's why it's great that we're talking about that in conjunction with the BPD label, because what could possibly create more toxic shame than being told that you have a disordered personality? But what I really want to touch on, which is a little uncomfortable for some people, there are a lot of people out there who claim to be reclaiming their BPD diagnosis, right? But at the end of the day, that doesn't change how society sees it. It doesn't change the fact that psychiatrists, doctors, and even therapists see that diagnosis and automatically assume the worst. And this is where I think a little bit of privilege comes in, because it's one thing to do what I did, which was very privileged, by the way. I went and sought out a BPD diagnosis. Some people, self-diagnose themselves on TikTok. They put it in their bio. They make content around it. Like me, self-call out right here. That's privilege. But that's not the reality for the most vulnerable people who get this diagnosis, because for them, it's not a quirky identity. It's not content fodder. It is a weapon that can and will be used against them. And I'm calling myself out here because I'm using myself as an example. I had all the best intentions. I was just a victim of this kind of propaganda around all of this too, but it's important to acknowledge the privilege inherent in this. It's the woman in a custody battle who has it thrown in her face in court. It's the person in the psychiatric ward who's instantly labeled with it and put on the back foot before they even open their mouth. And even the people who are reclaiming this label on social media and out here trying to do good work, I don't doubt that at all. I just don't think they fully realize how that label could and might be used against them too. And it's not to scare you, it's to empower you, right? Because the moment you have this label in your medical file, it follows you. You might not feel the consequences immediately, but down the line, when the doctor dismisses you, when a therapist refuses to take you seriously or even take you on as a client, when you realize that no matter how much work you've done, some people will always see you as disordered, that's when the reality sets in. And this isn't to shame anyone who has embraced a diagnosis. I totally understand why people do it. It's a lifeline. And as I said, it's training wheels sometimes to understand yourself, but it gives you an answer to pain that you've spent years trying to unravel. But I think we need to be aware of the system we're participating in when we do this. When you are handed a diagnosis that already puts you on that back foot, when you're told that you have a fundamentally disordered personality, how does that not result in toxic shame? How does that not reinforce the exact cycles of suffering that got you into the office of a psychiatrist in the first place? And when you already feel broken, when you already feel like you can't change, and a mental health professional confirms that for you and says, trust me, you don't want BPD, it's incurable, right? Where do we go from there? How does that foster hope? How does that create any room for healing? Because to actually heal, all three of us know we have to believe that we can change. That belief has to be there for healing to occur, that our story isn't fixed, that our patterns are not who we are. And that's why I fundamentally reject the idea that being handed this label could ever be empowering. It might be in your mind at one point, but it's inherently not empowering. And if transformation is the goal, then we have to stop handing out labels that tell people from the very beginning that they never can and never will change or transform.
Yeah. Yeah. As you were talking about diagnosis, and I too believe like sometimes diagnosis can be helpful in that it connects us to a community. We feel understood. We can read the things and say, yes, that's my experience. And we can have some kind of shared experience with
Absolutely.
other people. And when we're talking about these kinds of diagnoses, this podcast, FYI, is the first time I've ever said publicly that I have had that diagnosis. We talked in the beginning about how this was like a high threat for me. I had to do a lot of fear processing around that. But for me, like looking at these diagnoses, yes, it can be helpful in that way of connecting to community. And it's still not getting, for me, to the root of why it's there, right? Like for me, the thing that shifts everything and that reconnects me back to that space of we are neuroplastic, we are changing, transformation is possible, is going deeper to the level below. Like, again, these are just the outputs. So yes, I can find people that identify with these outputs, but I bet if we all looked deeper, we would also find experiences that connected us. The shared trauma history, the societal structures that led to these outputs. And when I can really start to see that, the why underneath, why was my nervous system and my brain shaped the way that it did? Why did I adapt this way? Then that lends itself to compassion and altitude and understanding of my behavior in a very different way, where I don't have to self-abandon, where I don't get catapulted into that toxic shame, because that difference there is really important, Mollie, that you brought up of, yes, shame is just a healthy, normal human emotion, quote unquote normal. We don't like to use the word normal. But when I have CPTS, it is a hallmark of CPTS, toxic shame. And very easily, I can be pushed from that calibrated amount of shame to help me repair my ruptured relationships into a huge, full-blown shame response, because that is how I was wired during my development, for that to be such a big reaction, right? And so for me, the antidote to that is to start to see underneath the diagnosis, what's going on, what are the patterns that were created, to understand my nervous system, my operating system, and to begin to work with it so that I maintain that constant knowing that these are just outputs. They're just reflections of my experience. It's not who I am. Who I am is very different from that diagnosis. And there's no part of me that identifies with that diagnosis as who I am at all anymore.
Beautiful. Really.
You know, this was an activating episode for me, more so than other episodes that we've done, for two big reasons: that I would be sharing some of my personal history that does carry stigma and shame, and is something that I've had to work through a lot myself. And also because we have many, many licensed medical health professionals in our community and NSI as listeners on the podcast. And I always want to make sure I'm really respectful of them, because I think that they're wonderful people doing good work, you know? And so we talked about really looking at it as the structures and the systems. All of that said, like, it was a big ask of my nervous system, right? Like, I did have to do a lot of processing of that fear that I didn't know that I still had, to come up against this, to look at this. And there was a moment of really reconnecting to that version of myself, because I haven't identified with this diagnosis for a long time, you know, since I'm 42 now, since I was 24 years old. So it's been like 20 years since I've thought about any of this, really. And I can feel detached from her, from that, you know, 15-year-old, 16-year-old, 22-year-old. And as I was processing that fear, I reconnected to her in a big way. The fear that she had of talking about this. And I knew that that's when I had to process the fear, and we had to have this conversation, because it's for all those other girls that think that they're crazy, you know, and have been violated so many times. And then it violates you in your mind, you know, your own identity, your relationship to self. And you're not, you know, you're not disordered. And so I did it for her, and I did it for them, because I think it's really important.
It's so important for your wholeness, and how you live in the experience of yourself, for those parts of you to not feel alienated or wrong in any way or crazy. So thank you so much.
That got me. All of us are crying. What really hit me, Elizabeth, is when you said part of you felt distant from her. And then it just made me realize how many versions of myself I am still separated from. And I tend to intellectualize everything. Obviously, it's come across in this episode. I'm still working on. I tend to channel my anger and my frustration with what happened to me into attacking these systems and picking them apart. But it is so important for me, and it's something that I'm dealing with right now, is figuring out how else can I also address what you just brought up, which is, I think that those versions of myself want me to be with them, you know? And if there is one thing I want listeners to take away from this conversation, it's this. And it's to little Elizabeth too. Well, not little, but 24-year-old Elizabeth. And, you know, the versions of both Jennifer, me, you listening out there. Your suffering is not a sign that something is fundamentally wrong with you. I'm going to try to get through this without crying. It is a response. It is a survival mechanism. It is your body's and your mind's way that it learned to cope with the environment that you were placed in against your will. And while those patterns might feel hardwired, like they're never going away, like they are who you are, they are not permanent. But It can feel really comforting at first to have that label, but we have to ask ourselves, does this diagnosis actually help me heal? Or does it give me another reason to believe that I'm broken? Because when I look at the history of these diagnoses, when I see how these categories were created, which we talked about, not discovered, created by committees of men sitting in rooms making decisions that are more about industry and social control than actual science, I can't in good conscience believe that these are the answer, because trauma does alter the way that we see and act in the world. We're all examples of this. You sitting there listening to this podcast, you know that. That's why you're here. But the things that we've been through, it shapes our nervous system, our relationships, our emotions. But those responses, those survival mechanisms, they can't be mapped onto this diagnosis that was just created, right? Rather than discovered through any legitimate biological science, right? It just doesn't stand up. And I think that if we really want to heal, we just have to look beyond those frameworks, because healing isn't about finding the right disorder to define yourself by. It's about zooming out. It's about doing what we just did today, questioning the systems and society, culture, family, all these different systems that told you you were broken in the first place. It's about remembering that no matter what you've been through, you are not a label, you're not a diagnosis, you are a human being that has survived. And if survival was possible, because it was, because you're listening to this alive right now, even if it's just barely, then healing is possible too.